Good afternoon, everyone. Welcome to the HL7 Da Vinci Community Roundtable. Today's session is Understanding the 2026 CMS Interoperability Standards and Prior Authorization for Proposed Rule, CMS-0062-P. My name is Casey Thompson. I'm the Program Coordinator for the Da Vinci Project, and it's my pleasure to open today's Community Roundtable. Before we begin, let's discuss that we fall under the umbrella of HL7's antitrust policies and engage in these forums to ensure appropriate collaboration and information sharing. Today, we're pleased to bring an overview of CMS 0062 by Denise St. Clair with the HL7 Da Vinci PMO and Vice President of Health Policy and Interoperability at Global Alliant, with Alex Goss, the Da Vinci Program Manager and Senior Consultant at Point of Care Partners, moderating. We will post a recording of today's webinar and slides on the Da Vinci video presentation page in Confluence, and Da Vinci's communications lead, Leslie Amoros, will be posting links in the chat box to assist in locating that page and other resources you may find of interest. Please be sure to use the Q&A question feature to submit your questions, as we've limited the chat feature for us to push these key details to you and enable you to download the chat box so you can save the links. We've also muted lines to aid our recording quality. And finally, we sincerely appreciate your survey feedback solicited at the conclusion of the webinar or at the point in which you depart the webinar. Our next community roundtable will be held on May 27th at 4 Eastern. Registration details will be posted on the Da Vinci calendar. You can also find a link to all of our community roundtable recordings and slides at the link on the slide. Upcoming events include the Weedy Spring Forum, May 11th through 14th. It's virtual. And the AHIP 2026 event, June 8th through 10th in Las Vegas, Nevada. HL7 events include the May 2026 HL7 Connectathon and Working Group meeting, May 16th through the 22nd in Rotterdam, followed by HL7 Fire Dev Days 26, June 15th through 18th in Minneapolis, Minnesota. The CMS HL7 Fire Connectathon is also coming up July 14th through 16th. It will be virtual. Registration will be available soon, and we have links to all of these events and more information on this slide. Okay, let's start with a few Da Vinci program updates. So let's do a quick review of our 2026 program priorities. This year, we will continue advancing our core functions with a strong emphasis on supporting our implementers, both directly and through our industry partners. We'll be putting significant effort into expanding our piloting activities, strengthening implementer engagement, and promoting shared learning across the community. These activities are essential to ensuring real-world success. We also plan to explore new and improved methods for engaging stakeholders in implementation guide development. And alongside that, we hope to develop a rubric to help assess investments in IG development and determine adoption readiness. This will give us a more structured way to prioritize and understand where our resources can make the biggest difference. Our work will continue to involve close coordination with our industry and federal partners, and it's important that we remain responsive to relevant policy opportunities like 0062 as they arise. In addition, we want to continue elevating the awareness of fire and collaborating to help the community better understand the value of fire and the meaningful progress all of you are driving through Da Vinci implementation guide development and piloting. Now, there are resources listed on this slide that you may find useful. At the bottom, there's a link to our Da Vinci in Action page where you can see who has implemented various Da Vinci guides to date, our Da Vinci LinkedIn page to hear more about everything going on at Da Vinci, a link to our YouTube channel with all of our recordings, and a link to all of our industry statement and updates. Okay, now this slide shows where our Da Vinci implementation guides currently sit in terms of maturity and STU phase. And there are several updates that have been made, which I'll dive into more of those in the next few slides. So first, we've had a lot of movement on the burden reduction side. The coverage requirements discovery, or CRD, document templates and rules, or DTR, and prior authorization support or PAS, new guides have all been published. And also there's a new guide for health record exchange, HREX. And then Patient Cost Transparency recently published their technical corrections update in March. You can find all the links to our new publications on this slide. Coming soon on the PDEX side of the house, there's an STU update related to provider access, which recently concluded a formal 2-week review period on April 24th. Next steps include ticket resolution and a submission of a formal publication request. So we look forward to bringing you that publication information very soon. Risk adjustment is also planning an STU update in May, which includes adding new operations, simplifying measure reports and remarks, and updating guidance so data can be submitted with a standard post request. And more information about both of these upcoming updates can be found at the links on this slide. And just so you know, we have a full list of all of our Da Vinci use case calls and meeting times in the appendix of this slide deck. You can also find all of our calls at the HL7 Conference Call Center at hl7.org and add them directly to your calendar. I encourage you all to get involved where you can. I added a few slides to provide updates on our pilot efforts. Our specifications, as you know, only get better when they're used in the real world, when we implement, learn from the experience, and then improve the guides based on what we've learned. And our trebuchet pilots began in 2024, and we've continued to grow and expand them. Our goal is to help providers and payers implement Da Vinci implementation guides ahead of compliance deadlines. We're also building resources to help implementers, including educational materials, lessons learned, and a community of practice where people can discuss their implementation experience. We have 2 new pilots as part of the Trebuchet initiative that we're excited to announce. The new Trebuchet Payer-to-Payer work group kicked off in March, and it's focused on advancing payer-to-payer data exchange. The group is actively testing both direct and network-based payer-to-payer exchange and trying to make that more actionable and scalable. Now, this work group meets every other Thursday at 1 Eastern. Anyone interested in getting involved with this group can contact Scott Rosignol, and his email address is on this slide. We also kicked off our new Trebuchet Clearinghouse cohort this April, and it's focused on advancing clearinghouse to clearinghouse prior authorization. Now, this pilot aims to reduce administrative burden by enabling scalable, standard-based interoperability between clearinghouses. And by extending Da Vinci prior authorization standards into this clearinghouse to clearinghouse model, the pilot is designed to support broader adoption and more efficient exchange across the industry. Now, Trebuchet pilots are all about learning from each other as we implement. We want to grow the community and bring in more implementers who want to build their FHIR expertise. And anyone can join our bi-weekly calls, and there's no cost to participate either in the calls or a pilot. And information on these calls is available on the slide, and it's also available at the HL7 Conference Call Center at hl7.org. And we have educational events as well, so I encourage you all to get involved. Now, our other pilot initiative is Patient Cost Transparency, and they're now entering year 2 of pilots with both payers and provider systems having tested the full end-to-end workflow for good faith estimates and advanced explanation of benefits, or AEOBs. Most recently, testing has moved beyond polling to using subscriptions, allowing patients and providers to access AEOBs more efficiently. We've also been testing how multiple providers can collaborate on a single estimate, giving patients a more holistic view of their expected costs for complex services like knee surgery. Now, our PCT pilot group meets every other Monday at 1 p.m. Eastern. And if you're interested in participating in this pilot group, reach out to Vanessa. Her email's on this slide, or you can reach out to us at the Da Vinci PMO. Happy to get you plugged in. Okay, now will we move on to the CMS-0062 overview with Denise. As a final reminder, be sure to use the Q&A option to submit your questions so we can keep the chat open for information sharing. Let's dive in. Welcome, Denise.
Thank you, Casey. Hi, everyone. So I'm Denise St. Clair. I am here with the Da Vinci PMO and also Vice President of Health Policy and Interoperability at Global Alliant, and excited to get to talk to you a little bit about a little new rule that's available for light reading when you have a moment. The next installment of the interoperability rules, and this is affectionately referred to as the prior authorization for drugs proposed rule. So if we can go to the next slide. One thing that we want to be sure just to level set on is that we're really looking at this with a Da Vinci focus today as we do a high level review of the rule. This presentation is not going to cover every single proposal in the proposed rule or all of the 5 RFIs. There's a lot of nuance, there's a lot of detail. In addition to the proposals, there's a really rich set of requests for additional comment beyond the formal RFIs, just within each proposal, all which really help you think through the nuances and considerations that CMS and ONC are looking at here. So we really strongly encourage you to deeply read the rule, but hope that this overview helps you dig into the content, see if you have questions, and engage as part of our consensus process as we are working to put together a response to the proposed rule for the Da Vinci community. So just want to make sure to level set on that. So before we jump into the proposed requirements for the 0062 proposed rule, I thought it'd be helpful to take a little dive back in time of the rules that got us here, because everything in the current proposed rule builds on requirements that have been previously finalized. So obviously the first interoperability rule that brought FHIR forward and the Da Vinci implementation guides was the CMS 9115 final rule, or the interoperability and patient access final rule. And this final rule really introduced the FHIR API concept. And really important is to remember that CMS is regulating those payers that they have the authority to regulate. So specifically, this rule is related to Medicare Advantage organizations, Medicaid and CHIP fee-for-service, Medicaid and CHIP managed care, and federally or QHP, qualified health plans on the federally facilitated exchanges. Now, one thing I will point out is that all of the interoperability rules that can get us to where we are today cover that suite of impacted payers. And of course, some nuances, again, proposal by proposal for the specific payer types. But one new thing for 0062 proposed is that it does bring in the SHOP plans into the qualified health plans for for federally facilitated exchanges. So something to keep in mind. But our initial requirements from 9115 brought in for those impacted payers the patient access API, the provider directory API, the payer-to-payer data exchange, which remember in its original form was not an API, and digital contact information, which if you might remember was the request to share endpoint information, and at the time the note was using NPES. At that time, implementation guides were recommended, and the recommended implementation guides to facilitate these various APIs were US Core Data for Interoperability, USCDI version 1. And you will notice here version 1 with an asterisk and then a version 3. And you see the same after FHIR release 4 for HL7 FHIR US Core IG. It starts STU 3.1.1 with an asterisk and then 6.1.0. If you go to the link, which is at the bottom of the slides, and of course the slides will be made available for you, there is a CMS website which provides the CMS guidance on APIs and relevant standards and implementation guides. And since the original publication of both the interoperability and patient access final rule and the subsequent rules, CMS, as indicated they would in previous rulemaking, has updated guidance to reflect more recently available implementation guides. And this is important. We'll talk about this again as we get into the current proposed rule. But what that page indicates is that the guidance has advanced to say that the adopted standards, which here are those with the asterisks, as of January 1, 2026. The adopted standards that expire on January 1, 2026, and then post 2026, you get to the newer versions of the standards. So this is where the recommendations evolved based on the evolving standards. So something to note, that page is really helpful and useful. Strongly encourage you to check it out as they indicate which of the more advanced standards are recommended as we progress through the standards in our HL7 process. So what's really important here is ultimately it was US CDI, FHIR release for US core, smart application launch, and focusing on ID Connect and OAuth 2. We had the FHIR bulk data access IG called out, as well as the Karen IG for Blue Button and Da Vinci PDEX, or the Da Vinci Payer Data Exchange IG, as well as the PDEX Formulary IG. All these IGs facilitating the ability to send and receive the data on the two required APIs, and then sort of alluding to the payer-to-payer data exchange. So that's where we started. If we go to the next slide, we then come to the 0057 rule, which we talk about a lot, which is the interoperability and prior authorization final rule. And this is where we bring in the prior authorization application programming interfaces. In addition, there was the evolution of the existing APIs and also the introduction of some of the new APIs, which we'll talk about more under the current rule. So you've got your patient access API and your provider access API and your payer-to-payer officially API, and then your prior authorization APIs. Now, digging in specifically to the prior authorization requirements in 0057, it's important context for the new proposed rule, because that's where we have some of our most significant proposals and additions. So in this rule, the introduction of the prior authorization API indicated that the impacted payers, again, MA organizations, Medicaid and CHIP, fee-for-service managed care, and the qualified health plans on the federally facilitated exchanges, that they must have an API that can provide a list of covered items and services, identify documentation requirements for prior authorization approval, and support the prior authorization request and response. So, as many of you know, that corresponds very nicely to a suite of Da Vinci IGs. So again, you have your recommended base IGs, again, recommended IGs, FHIR R4, US Core 3.1, now moving to 6.1, your smart application launch framework, and then the three specific burden reduction IGs supporting the prior authorization API as indicated in the rule. So you have your coverage requirements discovery, or CRD, which is the first piece of that puzzle. Then you have your documents, templates, and documentation templates and rules. So identifying the documentation requirements. And then the third piece, which is the prior authorization support IG, which is that actual prior authorization request and response. And so this rule did come with an enforcement discretion, which would allow folks to leverage the FHIR APIs and remain okay in terms of the HIPAA requirements, which of course HIPAA requires the X12278 for the prior authorization transaction standard. This introduced some decision timeframes: 72 hours for urgent, 7 calendar days for non-urgent prior authorization requests. There was a request for a provider notice, including a denial reason when a PA was denied, and it introduced prior authorization metrics, those metrics to first be reported in March 2026 for data from the previous year. And so all of this essentially initiated the FHIR requirements for prior authorization, specifically for items and services not including drugs. And so that's where we landed at 0057. And it did require that information about prior authorizations be included in the APIs as finalized in 9115. And so that's what brings us to the next sort of important set of requirements, which came from ONC in the HTI-4 final rule. And why it's important to note this is because what HTI-4 does is it says those three specific implementation guides, CRD, DTR, and PAS, are available for a health IT certification criteria related to electronic prior authorization, and that these are all consistent with the 0057 requirements and support providing folks that are in the Promoting Interoperability program and MIPS the ability to report a prior authorization measure starting in 2027. So of course, anything that is in the certification program that is not yet adopted into an official CMS program is voluntary, but it does set the stage for a certification requirement potentially in the future. Right now, totally voluntary certification opportunity exists per HTI for these IGs. So we really see this sort of trajectory moving us toward prior authorization on FHIR, leveraging the Da Vinci Burden Reduction suite of IGs. And that takes us to where we are today, which is the CMS-0062 proposals. Now, a lot of folks, based on the name of the rule, are very focused on that initial big proposal, which is electronic prior authorization for drugs. And that is one very significant proposal within the proposed rule, which is to incorporate policies and documentation requirements into the FHIR-based prior authorization API previously finalized in the 0057 rule to support electronic prior authorization for drugs covered under the medical benefit. So ultimately, this is leverage CRD, DTR, and PAS, not just for items and services outside of drugs, but also for drugs that are covered under the medical benefit. But for drugs that are covered under the pharmacy benefit, the rule proposes essentially a bifurcated standard. Use what's working, use what everyone has. Today, people are using the NCPDP standards for electronic prior authorization for drugs covered under pharmacy. So the proposal is continue to do that for pharmacy, but to include those drugs covered under the medical benefit in the FHIR-based prior authorization API. And then you have those two options for electronic prior authorization. For the NCPDP standards, the prior authorization proposal specifically calls out the real-time pharmacy benefit, prior authorization check, as well as the prior authorization request and response leveraging the script standard, and the specific NCPDP script transactions are listed out in the rule. So this is one of the flagship proposals, electronic prior authorization for drugs, medical benefit under the existing FHIR-based prior authorization API, pharmacy benefit leveraging the NCPDP standards. This bifurcated standard proposal is proposed with a compliance date of October 1, 2027, if finalized as proposed. Next slide. One thing that is also quite significant in this rule is not only is it adding to the existing capabilities of the previously finalized APIs, but it's also proposing to require FHIR implementation guides for the first time. In all of the previous rulemaking, the implementation guides have been recommended, strongly recommended, with a lot of signaling that they were very much desired for use. But this takes it to sort of the next level and proposes to require the FHIR IGs that had been previously recommended. The compliance date is the publication of the final rule so that the current unexpired IGs are required by January 1, 2027 and expire January 1, 2028. And then starting January 1, 2028, the current versions, as indicated in the rule, would replace the the current versions would be replaced by the updated versions indicated in the rule. So ultimately, what is this saying? This is saying that everything that is kind of in play today remains in play from January 1, 2027 until January 1, 2028. And then in January 1, 2028 is when you would move to the most current versions as indicated in the rule. This impacts all of the existing APIs, the patient access API, the provider access API, payer to payer, provider directory, and prior authorization APIs. Remember that the CMS 0057 rule required that impacted payers conform with the standards at 45 CFR 172.13 and 172.15 as maintained by ONC. So that's where the ONC rider in this rule comes in, as the proposed rule would update specifically 45 CFR 172.15 to incorporate the IGs as required versus recommended. And if we go to the next slide, we have the specific list of IGs proposed to be required. And so you've got your Karen for Blue Button IG, again, supporting the APIs originally proposed under and finalized under 9115. And this basically says, okay, we originally recommended version 2, but we are looking to require version 2.2 on January 1, 2028. For the Da Vinci Drug Formulary IG, it's originally recommended 2.0.1, but looking to require, starting January 1, 2028, the 2.1.0. PDEX, it's the same version for 2.1. For PDEX Planet IG for the provider directory, originally recommended 1.1, moving ultimately to 1.2 in 2028. And then for our suite of Da Vinci burden reduction IGs to support the prior authorization API, you have CRD and DTR and PAS were all recommended as 2.0.1 in previous rulemaking. And this rule is saying by January 1, 2028, be ready to require 2.2.1 for CRD, 2.2.0 for DTR, and 2.2.1 for PAS. There's also the bulk fire data access IG that was previously recommended and proposed to be required here, version 3. So one of the things that's really interesting to pay attention to, and something we've been talking about in the Da Vinci community as we've started working through our consensus process, is this sort of glide path to the newer IGs. One of the things Da Vinci had previously recommended in RFI proposals and previous responses to rulemaking was leveraging something like the standard versions advancement process, or SVAP, for standard advancement, appreciating that in this world of FHIR, we are moving more quickly than rulemaking tends to move in terms of standard advancement. So the rule does propose that there be the voluntary use of non-expired versions, and that the standard version advancement process kick in for future advancement of the standards. So a couple of things that we have been talking about and that could benefit from a bit of clarity is that glide path. So you've got, so for instance, if we look at the Da Vinci IGs for prior authorization, you've got the 2.0.1 versions that were originally recommended in the rule, but as we saw in our previous slides, CMS has indicated in guidance in on their website that they appreciate that 2.1 versions were more advanced and available, and were also on the list of recommended IGs. And per this rule, these earlier versions of the IGs would be quote unquote not non-expired until January 1, 2028. On January 1, 2028, these earlier versions become expired, and then you have 2.2. So we know a lot of folks in the community are starting to work against for instance, on the burden reduction IGs, the version 2.1 set of IGs. So one of the things we are thinking about in a proposed comment is clarify that in fact those 2.1 versions as non-expired are available for use through the end of 2028, and then starting on January 1, 2028, 2.2 becomes the youngest or earliest version you can use, and then it would advance via SFAP from there. So this gives folks sort of that glide path to the most current IGs, and there's lots of conversation and discussion and nuance in the rule around the ability to use newer available versions and how not to have rulemaking slow that process down, but to help people advance, but ensure, of course, that we're all working with interoperable versions and ultimately on the same page to advance the standards and interoperable transactions. So this is a big deal to move to the required IGs, and the versioning is something we've had a lot of conversations about. So again, something we'll ask for very clear guidance on in the final rule, and ultimately make sure everybody knows what their glide path is to that ultimately proposed January 1, 2028 use of the newest IGs. If we go to the next slide, we see an interesting progression. So everything that had been previously recommended is now proposed to be required in this proposed rule. But 3 new IGs that were not specifically recommended previously are now proposed to be recommended in the rule. And those include the Da Vinci Member Attribution List IG, and the CDEX IG, the Clinical Data Exchange ID, specifically referenced in several places for prior authorization attachments on FHIR. In addition, the rule proposes to recommend UDAP via the Fast Security IG. And so there seems to be a progression evolving here. Start with a recommended set of IGs in the rules, and then move to required. So that's interesting. There are, as I said, in every proposal, additional requests for comment, and some are about the future of recommending these, or requiring these 3 recommended IGs. But these are specifically called out in this rule as recommended for the proposals. So go to the next slide. We start to work through the additional proposals that we see in this rule. So obviously, I think the big ones and the ones everyone was focused on was adding drugs to the Prior Authorization API for medical benefit, adding NCPDP for the script benefit, and then the required IGs that support all of the APIs. But there's so much more in the rules as well. And so one thing is a proposal for a specific denial reason. And so proposed impacted payers provide a specific reason for denying a prior authorization request for any drugs, regardless of the method used to send the prior authorization request or decision. So again, this is building on what was finalized in 0057 for non-drugs items and services, and adding drugs in so that you also get that specific denial reason for a prior authorization for drugs. And this is in regard to information made available through the various APIs and making sure that that information can filter down. Prior authorization timelines, or timeframes rather, are also further discussed in 0062. So aligning with what was previously finalized for non-drug prior authorization requirements in 0057 for other impacted payers, the current proposed rule would also require that QHP issuers on the federally facilitated exchanges meet those same timeframes for the non-drugs items and services, because that was not previously included for that particular payer type So that would be the 7 calendar days for a standard or a pre-service claim for QHP issuers on the FFEs, or 72 hours for expedited claims, or a claim involving urgent care in this case. There are certain circumstances where for the QHP issuers on the FFEs, the proposed rule does suggest a 14-day allowance, and there's very specific criteria. I strongly encourage people to dig into those and see what those are. But this ultimately takes the opportunity to bring this payer type into alignment with the other payer types for the non-drug prior authorization requests. It also proposes timeframes for certain payers to provide notice of a prior authorization decision for drugs. So again, just this constant theme of bringing drugs into the previously finalized policies. Specifically, the impacted payers are state Medicaid fee-for-service, Medicaid managed care plans, CHIP managed care entities, and state CHIP fee-for-service. And the proposed time frame is no later than 24 hours from receipt of request would there be a prior authorization decision shared. For QHP issuers on the FFEs, it would be a standard request no later than 72 hours from receipt of request, and an expedited request no later than 24 hours. And so those are the time frames for the prior authorization decisions for drugs being proposed for the impacted payers. This has a proposed compliance date for all of these proposals of October 1, 2027. Going to the next suite of things, we have some more updates to previously finalized requirements, and there's quite a few requirements around metrics. Again, something I feel like we've discussed a lot in the Da Vinci setting across time, but for prior authorization metrics, there are a request or a proposal to update CMS-0057. And there's a few things that are of note here. One is aligning the timeframe for reporting to better work for Medicaid managed care plans and CHIP managed care entities. So the calendar year didn't really make sense for these plan types. And so the rule proposes to publicly post required PA metrics no later than 90 days after the end of a rating period, and to report these by both program and plan. And so as opposed to saying March 31st after the calendar year, which is what the requirements are for, say, MA plans, this is saying it makes more sense to base it off of the rating period. And so that's the proposal on that piece in terms of timing of the reporting. It does propose that all impacted payers report a numeric count of the PA requests as well as percentages for certain metrics. So previously finalized in 0057, for instance, there was the percent of standard requests that were approved was one of the metrics. And an update in this rule is to propose to say it's not just report the percent of standard requests that were approved, but also the total number. And so giving the number and the percent they felt could give a lot more context and make the data more actionable. So all of the previously finalized metrics are updated to propose including the number as well as the percent. And then there are 6 new metrics that are proposed to be publicly reported. And so these are detailed in the rule, but include things like the total number and percent of standard requests that remain denied after repeal, or the total number and percent of requests for which the time frame for review was extended and the request was denied. So there's quite a addition of rich data being requested in this rule for prior authorization metrics. And so in addition to the previously finalized set, there are also 6 new, and again, the addition of that, the number along with percent for reporting. So the effective date for the proposals for the prior authorization metrics, if finalized as proposed, would be the date of the final rule to be reported in the following year. So essentially, the next time you would go to report post final rule, assuming the final rule is, toward the end of this calendar year, it would then be impacted. So that is the prior authorization metrics. On the next slide, you've got the prior authorization metrics for drugs. So we had the updates to the prior authorization metrics for the original items and services, not including drugs. And then again, just aligning everything with bringing in prior authorization for drugs. You have the metrics for prior authorization for all drugs, excluding covered Part D drugs for MA PD plans, and that these would be reported by posting this information on a public website. So MA organizations, there are 15 proposed metrics to be posted on their public website by March 31st for the previous calendar year. So that timeline stays the same for MA. I'm just adding the additional new metrics that come in for drugs, as well as those that are already finalized, and the new proposed ones for the non-drug items and services. For state Medicaid and CHIP fee-for-service programs, there are 6 proposed metrics to be posted on public websites annually, again by March 31st from the previous calendar year. One of the things that's interesting to note here is that this rule also proposes that state and Medicaid CHIP fee-for-service programs report at the state level, whereas for MA organizations, it's at the contract level. And then at Medicaid and for Medicaid managed care plans and CHIP managed care entities, there's also 6 proposed metrics that would be posted on their public website. Again, this is the previous rating period at plan and program level. So that sort of new timing and plan and program level is carried across all the metrics. And for QHP issuers on the FFEs, there's the 15 metrics very similar to those proposed for MA organizations, posted on their public website annually by March 31, and this is at the issuer level. So the level of reporting and the timelines is consistent across all of the metrics by impacted payer type in the proposed rule. The compliance date is initial reporting in 2028 for 2027 data, and that would be for these new proposed metrics for prior authorization for drugs. Next slide. Going way back to the first slide we looked at, and 9115, the initial interoperability rule for patient access, there was that digital contact information proposal and finalized requirement. There is a proposal in 0062 to report payer API endpoints and associated information for CMS to publish that sort of builds on some of those early ideas for the same ultimate point of supporting discovery. And so the rule proposes impacted payers to report API endpoints for each of the required interoperability APIs. It proposes impacted payers to report the URLs for specific required documentation, which CMS would then publish for centralized access. Again, goal, easy discovery for developers. And so a lot of these things aren't new, but some of the nuances around them are new. So the URLs have to include the FHIR capability statement, authorization and authentication protocols for implementation details, and the API registration information. Now, what's interesting is that there's an alternative proposal here, as opposed to posting and reporting the endpoints for each API and the URLs with these specific pieces of information. There's an alternative proposal to leverage the National Director of Healthcare Providers and Services, or the NDHIG, and specifically the NDHIG endpoint profile and the related compliant resources that contain this information for each interoperability API. And so what CMS is looking is to understand from the community, what would you prefer? Would you prefer reporting as is happening outside of a Firebase API, or to leverage the NDHIG and use that for the purposes of sharing this information. And then CMS is looking to obviously make this information available through a central location. The compliance date is no later than 60 days after the effective date of the final rule that this information would need to be shared. For new plans, it's no later than 60 days before beginning coverage for new payers. And the rule proposes to report that any changes would need to be reported to CMS within 1 week of the change, and that impacted payers would have to verify this information every 12 months. So this is something to definitely look into and to evaluate both the base proposal as well as the alternative to proposal to leverage that NDHIG. Next slide. There are updates to the interoperability APIs, and in particular, there's a proposal to amend 0057 provisions and require information about prior authorization for both non-drugs, items and services, and drugs be included in the patient access API, provider access API, and to include new information about prior authorization for drugs in the payer-to-payer API. So ultimately, again, throughout the rule, you have updates to the existing and finalized proposals from and requirements from previous rules to ensure that we're also sharing information about drugs, and that prior authorization information ultimately is available in all of the previously finalized APIs. Compliance date is October 1, 2027. You may remember that a previous rulemaking did finalize API usage metrics, and specifically metrics about the use of the patient access API. This proposed rule proposes that Medicaid and CHIP managed care report to the state within 90 days of the end of the ratings period by program and plan. And that proposed QHP issuers on the federally facilitated exchanges report annually as part of their qualified health program certification program at the insurer level. And so those are some details around how and when those specific impacted payers should be reporting API metrics. But it does also then go on to propose that all impacted payers report annually MA at contract level, the fee-for-service, Medicaid and CHIP programs at state level, plan and program, as well as managed care, or issuer level for the QHP issuers, aggregated and de-identified data about the interoperability API usage. They didn't specify a form or manner at this time, but they did specify aggregated and de-identified. And in addition to the patient access metrics, there are new proposals for metrics for using the provider access, payer-to-payer, and prior authorization APIs. So quite a bit here worthy of digging into to evaluate exactly which metrics are being proposed for usage now of all of the APIs, at what level and at what cadence, depending on which of the impacted payer groups you fall into. The compliance date for this usage, metrics would be beginning in 2028 for 2027 data, similar to the other metrics. Next slide. One interesting proposal is removing drug formulary information from the provider access and payer-to-payer APIs. The rule indicates that it believes this information is otherwise available, but does have a specific additional request for comment if there's any use cases that may benefit from having the formulary data available in these two APIs. If this proposal was finalized, it would be final the effective date of the final rule. And there's also a proposal around denial or discontinuation of access to the provider directory API. And specifically, the rule proposes that impacted payers update the provider directory API denial and discontinuation policies to align more with the other API policies. Again, if you go back to the interoperability and patient access final rule, there was much more lenient requirements around denial and discontinuation of access to the provider directory API, essentially providing that access to exist longer and for more uses. And just to align the policies, there's a proposal now to really kind of bring that back and align it more closely with when you can deny or discontinue access to the other APIs, patient access, provider access, et cetera. That would be also compliant, the effective date of the final rule, if finalized as proposed. Next slide. Those are the tip of the iceberg in terms of the high-level review of the proposals as they apply to the impacted payers, consistent with the previous interoperability rules on patient access and prior authorization. There's also a very significant proposal in this proposed rule that is around prior authorization under HIPAA. And so this is no longer discussing CMS's regulatory authority for specific impacted payers. This is now switching gears and looking at prior authorization on fire under HIPAA as it applies to all covered entities under HIPAA. And this is really led by HHS and specifically the National Standards Group through its delegated authority from the Secretary to regulate policy under HIPAA. So there's two pieces of the puzzle related to prior authorization on fire under HIPAA. One is defining prior authorization. And so this is specifically looking at referral certification and authorizations and eligibility for a health plan. And for referral certifications and authorizations, there's a primary proposal to define prior authorization as an inquiry from a healthcare provider to a health plan to obtain authorization for care, and a response from a health plan to a healthcare provider about the authorization request. In addition, there's an alternative proposal essentially asking, should FHIR also be adopted under HIPAA for referral transactions? And so the alternative proposal would be to define referral certification authorizations under HIPAA to include inquiry from a healthcare provider to a health plan to obtain certification for referring an individual to another healthcare provider, and a response about that referral certification request. So that's one proposal under HIPAA for all covered entities. The other is related to eligibility for a health plan, which would be applicable only when used to determine whether a prior authorization is required. And it proposes to look at inquiries for a healthcare provider to health plan to obtain benefit information, including eligibility to receive care, coverage of care, and/or copays or deductibles. And it proposes to include the response from a health plan to a healthcare provider or another health plan about eligibility inquiry. So the definition of prior authorization on fire under HIPAA is one set of proposals to evaluate. And on the next slide, there is the next piece of the puzzle, which is adopting FHIR standards for prior authorization transactions under HIPAA. And again, really important that we've transitioned. We're no longer talking about just impacted payers. We are now talking about all HIPAA covered entities, so providers, plans, and clearinghouses. And what this proposes is to replace the X12278 for referrals and authorizations with FHIR, the US Core IG, Smart App Launch, and then specifically the Da Vinci Suite of Burden Reduction IGs, CRD, DTR, and PAS for the discovery, the requirements, and ultimately the prior authorization transaction. It is also proposing to replace the X12270-271 eligibility for a health plan for a prior authorization request with the HL7 Fire US Core Smart App launch and CRD IG. And then finally, on the next slide, it's looking to add, as part of adopting fire standards for prior authorization under HIPAA for all covered entities, the CDEX IG for referral and prior authorization attachments. So this is a very significant proposal evaluating the opportunity to leverage the suite of Da Vinci IGs and the component necessary fire backbone pieces to support a prior authorization on fire as an accepted HIPAA transaction and CDEX to support prior authorization and referral attachments. And of course, the attachments rule has recently come out. It did exclude prior authorization attachments, noted it would be otherwhere discussed, and here it is. And CDEX is what is being proposed. The compliance date for this would be 24 months from the final rule effective date. So 2 years after the final rule is effective, fire standards would become the prior authorization transaction under HIPAA if finalized as proposed. But small health plans would have an extra 12 months. So they'd have 36 months or 3 years to meet these requirements. And in addition, if that wasn't enough, there are also 5 RFIs included in the rule that are very worth your time and attention. One is looking at electronic event notification for value-based care and care coordination. Another is looking at increasing healthcare resiliency. A third is improving implementation for payer application programming interface technology. This one may be of particular interest to those on the webinar today. This also gets into some questions around certification related to APIs and FHIR for payer and provider. So very worth looking at very closely. There is an RFI on step therapy, and there is an RFI on laboratory tests and durable medical equipment, prosthetics, orthotics, and supplies items. So there are those 5 RFIs. Again, not enough time to dig into all of those, but strongly recommend that you take some time with those, if any and all of those are areas of interest to you. So with that, I will finally stop talking, and I think Alex will join me, and we can see if you have any questions for us.
Yes, we do actually have some questions today. One we've already answered. Hopefully, we can just kind of close the loop on that. There was a question about what is a shop plan. So I did clarify that it is a CMS regulated payer shop plans refer to small group health insurance plans sold through the federally facilitated Small Business Health Options Program, or FF-shop marketplace. So that was just one acronym we wanted to make sure folks were familiar with. But we do have some other questions that have come in, and I'm really grateful, Denise, for your presentation today. It really is gave me the opportunity to think about just how much things are being layered on as we look, more broadly at HIPAA to high tech to 21st century cures and the HTI rules. All of these aspects of rule promulgation with sub-regulatory guidances on CMS's websites really make this a very big indication of what's to come as we see this evolution of recommended to required, the capacity to get more iterative upgrades of base software, influencing the workflow interactions, creating more transparency via metrics and public reporting, advancing the nuances and aspects of the requirements, that we're seeing in policy and also aligning across APIs and related policies are all things that I heard you talk about in your session today, and they really resonated for me. So I might, if we have time, we might dive into that a little bit more. But let's tackle some additional questions that we have. So about 45 minutes ago, so in your early portion of your presentation, a question came in related to whether or not all drugs are excluded from 0057F and in 0062P.
And the answer is yes, essentially. So in 0057, it is items and services excluding drugs, very clearly excluding drugs. Everything in 0057 was just medical items and services. And then 0062 is including drugs, and drugs under the medical benefit are what, particularly for the proposal that is discussing electronic prior authorization for drugs leveraging the FHIR-based prior authorization API and leveraging the NCPDP standards for drugs under the pharmacy benefit. And so ultimately then that covers everything. One way or another, you have an opportunity for electronic prior authorization by using one of the two standards, whether it falls under medical benefit or pharmacy benefit.
And that's really the key point is that your decision tree says medical or pharmacy benefit plan, and then you know which way to go, FHIR or to the NCPDP standards. We did have a comment that I just want to at least acknowledge that the NCPDP formulary and benefit V60 is also included as a part of this rule and is needed to work hand in hand with the real-time pharmacy benefit check, providing plan level benefit information. And I think probably we just for slide where we did not include all the nits and nats, which is part of your disclaimer in the earlier part of the presentation, that with time and the scope of the size of this rule, we could not cover everything, but just didn't want to lose that point of observation for the broader audience. So we have another question from about, do you have a table or a visual that shows all of the requirements of 62P and their implementation date? And I think that's an interesting question because I think our federal colleagues might have that for us.
Yes, we can have one of our amazing folks on the line here. For those who are Da Vinci members, I will say that there is a consensus process ongoing where we're talking about our response to the rule, and there is a Confluence page that has a link, but we'll get that link for you because the CMS team did do a wonderful presentation, and there is both a slide deck and a video of that presentation. And I think the slide deck does a good job of consolidating a lot of the requirements. I will just say it does make some pretty tables and charts, but again, there's so much nuance in this rule that if time permits, if any of the particular high-level pieces catch your attention, I strongly recommend that you dig into the rule to get more of the detail, but those resources are wonderful. And we can work to get you those and already done because Alex is a very good multitasker.
Well, because
So
those are really critical resources, so I had them at my fingertips
wonderful.
talking today. So great question, and I appreciate the plug for the Da Vinci member community, the Da Vinci members to join the consensus process. And let's now go to our next question. Does the rule discuss centralizing all of these APIs? In other words, are EHRs and providers expected to maintain the thousands of APIs required to connect to all payers?
So is this more of around the endpoints to sort of make sure that you can get to the right endpoint for each of the particular APIs for the appropriate payers? And in in that regard, that is where the new requirements around the publication of endpoints comes in, and the interesting alternative proposal to leverage the National Healthcare Directory IG for that purpose. And there are words like central and discoverable included in those proposals. So clearly there is an intent and a desire to get this information in one place and make it easier for developers and others to find the right endpoints for the right APIs. It's also interesting if you think about the proposals around the recommendation for the UDAP security standard through the Fast Security IG, in that UDAP is very much network friendly, as opposed to the true point to point that is, ID Connect and OAuth 2, which is what was sort of underlying the security requirements in the previous rulemaking. So again, we're seeing this signaling, reading tea leaves, this is my opinion, we're seeing signaling to make this much easier, more discoverable, have central locations, even just the not related to this rule, but other conversation around the National Healthcare Directory and some of the proofs of concepts and things that are going on within the health ecosystem. This really does sort of point to a desire to make that easier for the community. But that alternate proposal is something very valuable for you to check out
Mhm.
and comment on, particularly if this is of interest to you.
Yeah, I really appreciate you weaving in that perspective to the CMS health tech ecosystem, and the fact that, there's a push there as well with other entities looking to prove out the scalability and help everyone with the lessons learned to get to that level of scaling using these FHIR APIs. So thank you for answering that question. Um, Kind of a broader question came in around how much overlap do you see among proposals impacting different actors, such as measure reporting for Medicare and Medicaid plans?
There really is. It depends on how you're finding overlap. So there's a lot of synergy, I
Yeah.
think. There's a lot of desire to be consistent in what is requested of Medicare versus Medicaid, Medicaid managed care, Medicaid or CHIP managed care. And so from Medicare Advantage, which is in the rule, and the QHP issuers, like it was interesting to me to look at the metrics. The metrics for prior authorization and prior authorization for drugs in particular are identical for MA and QHP, with just like some wording nuances around the way the programs refer to the drugs that are accessible in the program. But for the Medicaid and CHIP plans, there were much less. So I think it's 15 metrics versus 6. So I think that's partly due to how the programs work, and then partly I think there is a burden consideration.
Hmm.
And so it's interesting to look at that. But there's synergy around the similar payer types. And if you're talking about Medicare fee for service versus the
Mhm.
impacted payers, that's always a conversation. So I think that's something CMS has said and shown in recent years is the desire to do what we are requesting others to do. So when the patient access API came out, their blue button moved to FHIR. You see a lot of the evaluation of the opportunities to leverage the interoperability standards and FHIR-based tools. But it's within the rule, there's a lot of internal consistency. And then between Medicare fee for service and the regulated plans, then that's I think where CMS is consistently working to walk the walk.
Yeah, I appreciate the fact that they not only regulate, but they are trying to do that, the walk the talk sort of aspect. So this is a question we may have sort of already covered, but I feel like there might be a nuance in here that I want to see if we need to tease out a little bit. Does the requirement to include drug prior auth information in the provider and payer APIs or the access APIs apply to both medical and pharmacy benefit drugs?
So the requirements to include drug PA information, it very clearly says all drugs in the proposal. And I think it's even bolded a couple of places.
Yeah.
So it does say all drugs, and in a few other places you'll note it says regardless of how the electronic prior authorization, or
Mhm.
it doesn't even say electronic, it says regardless of how the prior authorization was submitted. So that wording would make me think we are talking all medical and pharmacy, and that if the desire is to ultimately propose this bifurcated standard of prior authorization, either through the Firebase API or script, that there's a assumption that then that information is accessible to you in a way which you can share via the other APIs. So definitely something to think through and consider and comment on.
Yeah. Thank you. CMS 0062 speaks of requiring use of unexpired versions of standards. How is the use of expiration in the rule and in other standards contexts different?
Excellent question, because we have had this conversation.
Yeah.
Um, a little who's on first for a minute there in some of our conversations, but unexpired means something very different in HL7 than it is as it's used in this rule. So that's something that's, I think, really important for standards conversation about the rule. Generally speaking, an expired IG is still perfectly usable in the HL7 world. It's just not being advanced or worked on any further. That's way shorthand, but the general idea. Unexpired versus expired IGs as it's leveraged in this rule is very different. Essentially, what CMS is saying is once an IG is considered expired, it is no longer compliant with the regulation. You are no longer doing the right thing per the requirements if you use an expired IG. And the concept is clearly an attempt to move folks to consistent and single versioning to support that interoperability. But it's also providing a bit of a glide path to get there. So that's where it could be more clear. I think it's something our community has noted to date, and something we will note in a response, is that there are those early versions of the IGs that were originally recommended in the various rules, as we showed in the early slides. And then on the CMS website related to IG guidance, there is an indication of that next level. So if we think about like CRD, DTR, and PAS, you went from the 2.0 series to the 2.1 series. But in rulemaking, we've gone from 2.0 to 2.2 specifically called out. But the way it's explained is essentially you can use the unexpired versions. That gets you the sort of 2.0, 2.1 through the proposed date of January 1, 2028. And then starting on January 1, 2028, they would quote unquote expire the 2.0 and 2.1 versions, and that would mean you should use the 2.2 versions of the burden reduction IGs, and then in the future, they would leverage SFAP to continue to advance the standard. So that is a very different way of using expired related to an IG, and important in sort of evaluating the rule, but also something that I think we've collectively decided could be a little bit more clear. And so something that we'll definitely note in a
Yeah,
comment
I think
response.
that the language aspect is we all learn the policy and what the terms in the policy mean does take some time for us to all get semantically aligned, and hope the folks that are actively engaged in standards world won't get confused by all of that. And so hopefully some of the final rule will bring us a little further clarity and align all of us.
Yeah, and also help with the clarity around, because you've got, and that was one of the sort of points of starting with 91150057 HTI4. In each of these, you have versions of IGs recommended, and then you have the required versions in this new rule, and just having that real clarity around the expectations of that glide path to these newest versions and ensuring compliance. From the proposals in these rules, as well as the certification, the voluntary certification option, I think is important. So something we can call out.
Another question that came in is the intent to surface the payer FHIR endpoints for CRD, DTR, and PAS and include drugs on that interface in a way that the payer would then integrate on the back end with the appropriate PBM. Do you want me to say that again? Because that's not an easy question. Is the
No.
intent to surface the payer FHIR endpoints for the burden reduction IGs and include drugs on that interface in a way that the payer would then integrate on the back end with the appropriate PBM? It
So,
feels, go
oh, go
ahead.
ahead. No, you go ahead.
I was going to feel like that's an architectural decision that would have to be made by the organizations. I think that the FHIR endpoints for CRD, DTR, and PAS related to medical is one
Medical
thing,
benefit.
unless you're in the aspect of the access APIs, which is the data flowing in another way. So I find myself further pondering the question.
I think it really depends on sort of how you are implementing the bifurcated standard, in the sense that you've got the FHIR APIs for your medical benefit drugs, you've got NCPDP script for your pharmacy benefit. Generally speaking, you're probably working with your PBM for your pharmacy benefit, but I am not an expert, so cannot tell you if perhaps you engage with your PBM for anything else. But then you will ultimately want to report some of your prior authorization metrics for drugs. You'll want to include information about all your prior authorizations, to Alex's point, and the other APIs. So do you need to share that information within your system, but does that really require you to expose endpoints to your PBM? That would really depend, I think, on sort of how you're thinking about it, unless I am missing a nuance here. But I
Well,
think that,
there's
yeah,
a couple follow-up nuances that I think are
okay.
related that were submitted on this about the drug prior auth flows to be in the provider workflow. And I'm feeling like the questions, so it's the payer FHIR endpoints. I'm still connected with how disconnected for the FHIR endpoints work with this drug flow in an EHR environment. So I think maybe there could be the person that submitted this question, if you could re-ask it, that might help us get you a more useful answer.
Yeah. So, I mean, I think that seeing the last sort of piece on the real-time benefit check. So technically CRD, if CRD is operating within your workflow, then I can, as a provider at my EHR with my patient, evaluate, is prior authorization required for this particular item or service? And in this case, it would be item, service, and or medical drug under the medical benefit if I'm leveraging FHIR, because CRD is covering me for non-drug items and services and drugs under the medical benefit. So I would, within my workflow, if that is how you choose to implement CRD, which allows you to implement this within the provider workflow, also else in other ways. But if I'm there, I can then evaluate that and say, yes, this medical benefit, this drug under the medical benefit is required for prior authorization, or it's covered, or it's this, and I can move through my CRD, DTR, and PAS workflow. And you can have that information in the workflow. Just like if you're looking at a drug for the pharmacy benefit, the real-time benefit check will allow you to evaluate what your options are, what requires prior authorization, what your copays and things might be within, if you've got that set up within your workflow. So if you've got CRD, DTR, and PAS operating within your workflow, then yes, you would be able to also see the coverage requirements for drugs under the medical benefit, which are proposed to be required as part of prior authorization in this rule. And then separately, for drugs under the pharmacy benefit, you would have the real-time benefit check. And again, part of that will go down to how have you implemented the implementation guides and the workflow in your process. CRD, DTR, and PAS are absolutely, and we have heard recommended to be used within the provider workflow. As a patient, I'll just speak for myself, love that idea. But it's interesting. There's a clinical advisory council letter on that if you're interested from the Da Vinci Clinical Advisory Council. But yeah, so in that way, it would be accessible from the workflow.
Well, and there's also an offer to talk later about this, but there does seem to be also a perspective around patient cost transparency
Hmm.
and RX prescriptions in one flow and how that can relate. So I love the advanced baseball thinking on that, and we would welcome a follow-up conversation with that submitter. They can just let us know when they would like to have that conversation. Um, our interchange appears to have Claire, I brought up another question. So the rule does not require EPA in the provider workflow?
So the rule proposes to require the use of the Da Vinci IGs for the purposes of prior authorization. The IGs provide the opportunity to include prior authorization in the workflow, and then per the um, community involvement and consensus, there's also an opportunity to implement those IGs more on the sort of back end business side. That has been a topic of conversation, and it's definitely an interesting topic. But the IGs permit the ability to have it in the workflow. The rule does not say how you must implement in your business process. It simply says you need to use the IGs if finalized as
And
proposed.
does this also the lack of requiring it in the provider workflow really relate to the fact that the authorities of the policy proposers in this rule are not the same that actually have authorities over the EHR certification program, but we do see there are levers across the CMS. I'm going to make sure I get this right, promoting interoperability and MIPS programs that leverage these standards and capabilities as we see ONC putting also requirements in their certification programs. So I think
Yeah,
it has to do with who can specify what where and then how our federal partners like work together to uh, use each other's work.
yeah. And that's again really important. It gets even more confusing in this rule as we were talking about it, in the sense that you've got CMS has authority to regulate the impacted payers, the Medicare Advantage organizations, Medicaid and CHIP fee for service, Medicaid and CHIP managed care, and the qualified health plans on the federally facilitated exchanges. Those are on the payer side. That's where the authority lies. That's the main focus of the requirements in the rule. But then you have the additional requirements that are by, HHS requirements under HIPAA, and that is all covered entities, which includes providers and payers, which would make, obviously the IGs available for use as prior authorization transaction under HIPAA. And so that's the one place where providers specifically come in this rule. Otherwise, CMS themselves, to your point, they're regulating the payers, not the providers, but ONC does oversee the EHR certification program, hence HTI-4. That is voluntary at this time, but of course, CMS has in the past picked up those requirements and made them part of other programs like QPP. So there's a very symbiotic relationship, but it's really important, especially as you're looking at this rule, to make sure you're focusing on when am I looking at a policy that is specific to impacted payers? When am I looking at a policy that is all HIPAA covered entities? Where do the payers fall? Where do the providers fall? And then where are the opportunities to just choose as a implementer where and how you leverage the standards and ultimately remain conformant and do what works within your workflow.
Just a little bit of stuff to think about there. So we had a question that I'm want to ask you, and I think that it's a little bit of could take us down a little bit of a rabbit hole, so it might be our last one. Has an analysis been done validating that CRD returns all of the information that a 270, 271 can? And that gives me personal pause as having somebody who's worked with the eligibility transactions extensively in the past. The 270, 271's got a lot of capabilities and they've been adding to it. So I think that there's, for me, a little bit of a concern in that question, in that the CRD isn't expected to match the full capabilities of a 270, 271. A CRD is related to prior authorization coverage requirements discovery. And so I don't think that's an apples to apples comparison, but I'm curious as to your thoughts on it, Denise.
I never want to definitively say one way or another when we're talking about the comparisons because I feel like there's so much nuance and so much opportunity to really dig in. I do think it's interesting, and I was actually, because I can't get back to my own slide, the way it is worded in the actual proposal. Um,
Is there a particular slide you're looking for? Maybe Casey can take us back there.
you'd think I'd be able to find it on my 14th monitor. Just kidding. Oh, I found it. Hold on one second. So, so the way it is listed in the rule, in the proposal is to adopt the following fire standards and specifications um, for healthcare eligibility inquiry response when used to determine whether a prior authorization is required. And this is what is considered the current 270, 271 standard and specifically calls out Fire, US Core, Smart App Launch, and the CRD-IG. Now, what I find interesting is that per the proposal, it does say healthcare eligibility inquiry and response when used to determine whether a prior authorization is required. So it's specifically calling out the CRD to capture that piece of
Does,
eligibility for a health plan transaction.
Mhm.
And there was actually some conversation on this specifically. It caught my attention, which is why I wanted to go back and look at it, the wording, because it caught my attention when CMS was doing their presentation on the rule. Um, David did take specific care, David Koppel took specific care to mention that. And so I think it's definitely worth a close read of that section of the proposal around the X12 270 271 transaction standard and specifically which piece of the puzzle that CMS is suggesting that CRD be able to cover. And again, it's really important to focus on the determination of whether a prior authorization is required and the eligibility inquiry and response for that. So that's something I think it's worthy always of taking back and doing a good close read, but that is the specific wording as laid out there. So that might be a homage to the fact that there could be much more there, but specifically we're talking about the ability to do really what CRD was intended to, which is, are you eligible for this? Do you need a prior auth?
Well, I can't believe it. We're actually at the bottom of the hour. We've come to the close of the webinar. It's been really great to be able to moderate these questions and also to hear your review of the nits and nats overview of the proposed rule. It helps the more we hear it, the more we internalize it, the more nuances we're going to ferret out from from the writings and provide us with an opportunity to make clarifying questions and comments back on the proposed rule, which I believe comments are due June 15th. And so we encourage everyone to check back in. We'll probably have some updates for folks at the May Community Roundtable on the progress we've made within the Da Vinci community. And of course, in our usual fashion, any of our public comment letters that we submit, we will post to our main Da Vinci Confluent space. So we look forward to seeing folks on the next call. And in the meantime, we hope all is well and wish you a great balance of your day.